Bacterial overgrowth. Etiology, pathophysiology, and pathology. Akin to fresh water in a free-flowing river compared with stagnant water in a pond, bacterial overgrowth is promoted by any condition that impedes the normal flow of intestinal contents. The normal small intestine is not sterile but houses less than 104 organisms/ml. In bacterial overgrowth this rises to 104-109 organisms/ml. The mechanisms by which such bacterial overgrowth produces diarrhea, usually steatorrhea, are not completely clear, but deconjugation of bile salts by bacteria may interfere with fat micelle formation and thus impair fat absorption. Other mechanisms may include direct damage to the enterocytes and mucosal surface or brush border enzymes, or indirect damage by deconjugated bile salts. Bacteria also metabolize vitamin B12. Epidemiology. Incidence and prevalence are unknown but may be decreasing as a result of reduced surgical intervention for peptic ulcer disease. Clinical presentation. Common. Chronic diarrhea or steatorrhea. Uncommon. Neurological disorder, e.g. peripheral neuropathy, subacute combined degeneration of the spinal cord, secondary to B12 deficiency. Folic acid deficiency in the elderly is sometimes the only indicator of malabsorption. Physical signs. None due to bacterial overgrowth per SE. Look for neuropathy and associated diseases, e.g. Crohn's, previous peptic ulcer disease surgery. Investigation. NB. Bacterial overgrowth. Be alert to the diagnosis in patients developing diarrhea who have a predisposition for this problem, e.g. those with structural abnormalities of the small bowel. Glucose or lactulose hydrogen breath test. This is the usual diagnostic test. Glucose is absorbed completely in the upper small bowel. If bacteria are present, they will metabolize glucose to hydrogen and methane and cause a rise in breath hydrogen or methane. Lactulose is a non-absorbable synthetic disaccharide that is metabolized by colonic bacteria. Bacterial overgrowth of the small bowel causes an early rise, but false positives may occur with rapid small intestinal transit. Jejunal aspiration and culture. The gold standard for diagnosis, but invasive and rarely used, although it does give bacterial sensitivities that can be useful for optimizing antibiotic regimens in those patients with resistant bacteria. Small bowel follow-through. Small bowel radiology is indicated to look for diverticula in those patients who do not have a known underlying structural small bowel abnormality. Treatment. Antibiotic treatment with the aim of suppressing bad bacteria in favor of good bacteria. Augmentin, CO-amoxiclav, or a 5-fluoroquinolone has been shown to be effective. Some patients require cyclical rotating courses of antibiotics. Vitamin B12 injections may be required. Complications. Malnutrition, neuropathy, and deficiencies of fat-soluble vitamins. Prognosis. Most of the predisposing conditions are not correctable, so is often a chronic recurring condition unless cyclical antibiotics are employed. Morbidity probably mostly due to lack of diagnosis. Unlikely to have any effect on mortality.